And I think that's what our patients want. They want to have their priorities seen, and they want to know when they might leave hospital, because every day does matter for them. How can we get patients out of hospital quicker? Helping us then get patients into those beds that need them acutely. What's been introduced is the estimated discharge date. So looking at a patient as they enter the ward, what would we expect them to, what date would we expect them to leave on? So what we were looking at was ensuring that all our nurses were recording the same information. So we use CPL, which is the consultant patient list, to start electronically putting plans in place and using that as our handover as nurses, and the doctors documenting their plans and tests that were going to happen within that CPL as well. So if you're an OT, if you're a physio, if you're a doctor, a nurse or a speech and language therapist, you will have access to that information. You will be able to see it live as it happens within the MDT. So our doctors would document at the time of the MDT what the plans were from that MDT.
So as a ward, we've been all making sure that every patient has an estimated discharge date on their, both on the computer system and in their notes, which helps us work collaboratively as a team and as partners of the MDT.
During MDT, I make sure that all the EDDs are recorded on the system for each patient, and if there isn't one, we challenge the doctors or whoever's there to make sure that one of those is inputted for each patient. Beforehand, EDDs weren't a main focus, so we weren't recording them during MDT meetings. So now we're able to have sort of a plan in place to know when patients are going to be discharged, and get the OTs involved and the discharge coordinator, and obviously they can plan where that patient might be going.
And that helps us then, because we can prioritise our daily lists and know who we're going to see across all of the healthcare of the elderly wards, and to do our functional assessments, our initial assessments, our mobility assessments in a timely manner to make sure that we're not delaying the discharge when they are medically fit and when they're ready to go, so that everything's tied up at the same time, so as to not delay them leaving hospital.
Well, I would hope that when a patient arrives at a hospital, the first thing that the hospital would create would be a critical path, something that the patient could understand, with the ultimate object of a successful discharge. Because I feel communication is, even at a very low level, is what the patient needs to be aware of, to feel that kind of confidence that they know where they are on the ladder.
Yeah, so during our MDT meetings, we talk about each patient, and then I go through the needs that I might need to make sure that we've got their frailty score in there, their EDD score in there, and the discharge coordinator being there, so then we can sort of put a plan in the notes to, you know, where they might be potentially be going or what therapy they need.
Having an EDD has had a good impact on the patient, because it means that we're reducing their length of stay, and for every day spent in hospital you're more at risk of deconditioning, and therefore they might need more packages of care, they might need more therapy. So trying to get them out to that, you know, whether that's home, a community hospital or a care home, means that they've got that chance of a better outcome when they leave us, really.
And they're more aware of what's going on as well, so that patient knows that there's a plan in place for them. It's quite crucial that the ward clerk is there, because we get phone calls from relatives, or they come up to the desk and they want to know quite rightly what's going on with their relative. So we've got a bit more of an insight to them. So whether it's to say that they're going to have more therapy, or that their plan is to go X, Y and Z, it's a bit more comforting for them that they know that their loved one is being looked after, and things are being put in place.
We also knew that there were issues with TTAs, so actually at point of discharge, were we able to discharge that patient because their medications weren't ready to go, their discharge summary wasn't ready to go. So we decided to have a prioritisation board. That allowed us to look at those patients that were going on that day and clearly document that we needed those TTAs done for that day. So we used it as a prioritisation board for all aspects of care. So actually, if the OT needs to do a practice of everyday living with a patient, then actually that can go on the board. And these are all questions that we can ask and then give the information back to our patients. Having access to information immediately should lead to better communication.